all about MELAS and benign prostatic disease. So we keep our vision in the evolving landscape that is shown here. I mean, what you have in deep green is recommended by our guidelines strongly. The green is recommended weekly, and the other one either is not described or is not subject to recommendation. Of course, all these things are evolving in terms of technical, surgical techniques regarding enucleation, but the right column of all these alternatives are subject to more and more research and modifications. The first highlight I want to do is a big tribute to Marcus Drake, who presented this magic slide that cost him £2.5 million and 8 years of work by the upstream trial comparing the urodynamics to standard of care before TURP. It has shown now that the predictive factors leading to failure of surgery have been identified. They are bothersome if there is slow stream, if there is a severe burden, if there is a bad quality of life, if there is a young patient without comorbidity on the right. Your surgery has a lot of chance to be good. If you get on the right with all these items, your surgery might be even worsening the patients. When we focused on specifically on the surgical techniques, we had the EXPO trial coming from Milan, which is a prospective, observational, as frank as it could be, of a clinical practice of HOLEP in an expert centers after having crossed this learning curve with thousands and thousands of patients. It shows that in real life, I mean, you have complications. Complications do exist, intraoperative, postoperative, early and lately. This is not nothing. The continence after HOLEP slowly recovers during the post-op, up to 1 year with a plateau, and we can see that the sexual function is already impacted at the beginning and recovers in terms of IIEF, but enucleation is leading always to ejaculation disorders. Few studies have done a propensity score matching between aquablation and HOLEP, because you know an RCT is awaited. The results are not here yet. They will be hopefully in Ferris. So what we can see with aquablation and HOLEP is that it's leading to quite similar results. The intraoperative complications are not quite different, but there is still in post-op this issue about transfusion and bleeding with aquablation, according to this study. There was a presentation by Naim Bojani on behalf of the Water 2 research group for aquablation in big prostates. So the people who were treated were quite similar to what you have in your clinical practice with big prostates. They had complications, but I mean, it was quite satisfactory in this group, according to the research group, with a nice sustained result with time up to 5 years, which was a priori the possible drawback of these big prostates was under treatment. It seems it's not. Robotics for big prostates are more and more an option. In this trial from Alex Mutri in Aalst, I mean, they compared that to a historical cohort of HOLEP, and they have seen that they can have good results. I mean, it's absolutely not randomized. We do not progress in terms of potential of recommendation, but it's definitely feasible, and this is maybe an option for the future, but definitely not mature in terms of methodology and in terms of quality of the evidence. If you look to less invasive procedures, the resume is investigated. You know, it is also subject to an RCT, but compared to medications, that has no results yet again. So we had some prospective cohorts like this one from the UK, which has shown in specific population of the large prostates, quite nice results with a long-term analysis. You can see that the IPSS quality of life and IPSS change is one maintained, but we still have concerns because it was a very low number of patients. A significant number of them get retreatment with medications or have more surgeries. The TPLA was also described as a randomized study, but it is something that is just popping up. I would just summarize all this with this new diagram. That is, I think, the kind of trade-off we can have between invasive and less invasive. You have less deobstruction, but you have less adverse events. So that's potentially the role of these future stents and cages that we have seen, but for the moment, they do not satisfy, even if nice results like the Optilum has been presented through the Pinnacle trial this year by Stephen Kaplan. Just an update. Remember this last slide, that the rules of the house, at least at the EAU, have to be proof of concept. We have it. The placebo comparison, we still need it. And randomized are the only thing that make us sure we can recommend treatments for the future. So these future challenges are here. Getting the best Qmax is something, but reaching patient goals is better. We have to switch to surgeon values and preferences to patient values and preferences. And we have to consider that sexuality is not only ejaculation, and progress, of course, on decision making among all these options through better guidelines. I thank you so much.